if at any point it starts freezing again, we'll just nix it and do something different. But so guys, if you guys didn't hear, Dr. Shai is a board certified psychiatrist. He works in Austin, Texas. And please, any of you guys, if it freezes, let me know because this is my first time doing this live as well. I'm Dr. Hassan, board certified anesthesiologist. You guys probably seen my videos and or my TikTok lives. And this is Dr. Shai. Smash that like button, please. I'm trying to get back to I need to ask about borderline personality disorder. We'll get to that. Izzy, we're going to go through a couple of questions that we've talked about before, and then we'll do specific questions. So the first question that before we do that, let's just talk about your background one more time, Dr. Shai. Can you tell us where you're from and what you do?
So sure, born and raised in Maryland. So grew up with Dr. Hassan. We went to middle school together, been friends ever since. And then I went to college at UMBC for my undergrad, University of Maryland, Baltimore County. Did my medical school in a town called Dayton, Ohio, at Wright State University, Boonshaw School of Medicine. I stayed in Dayton at Wright State for residency, and then I transferred to UT Austin for my fellowship training in child and adolescent psychiatry. And stuck around since, so I'm still in Austin.
Fantastic. So you practice in Austin, Texas, as a board certified psychiatrist. We're gonna skip to the second question, and then we'll come back to the first at the end. How about we do it that way so that people don't get bored? Whoever got to hear the question in the first round. The first question we'll go over today is marijuana, medical marijuana. So, Dr. Shai, can you talk about the effects of marijuana, the psychiatric effects of marijuana, what you see on a day-to-day on a day-to-day process with kids and adults, and what kind of long-term effects you get from daily marijuana use?
Sure. With regard to marijuana, I've never prescribed marijuana. I don't think there's really strong evidence that shows that it's better treatment than some of the more established ones yet. I mean, I think it's something that's still being studied. We'll see sort of how that develops in the future, if this is something that will become more used therapeutically. But I mean, as far as sort of just marijuana use is concerned, I mean, it's really prevalent, and I don't think that's going to change anytime soon. To say that it's not going anywhere. People are going to continue to use marijuana. So with that in mind, I mean, I think that I think as a physician, you just have to have open and honest dialogue with your patients, just to in a non-judgmental manner, just to understand sort of what each person's relationship with marijuana is. Again, without sort of getting into specifics, but case by case basis of where that would be maybe possibly interfering with treatment if it is something that is going to interfere with other medications, for example, or other therapy modalities. Then you just want to sort of have that in mind, just have that conversation and sort of see where a person is at, and then kind of make recommendations to kind of work with your patients on meeting their goals.
What kind of role do you think marijuana has in pain, chronic pain, acute pain, anxiety, that kind of stuff?
So I don't really treat pain, not directly. I think, and pain and mood are kind of two sides of the same coin. In exercise, I often have people do that are patients with chronic pain. Is I try to walk through what was the happiest moment of someone's life, and then I sort of ask them so if you imagine that moment, if you're still having the same pain that you're in right now, would that still be the happiest moment of your life? And invariably people will say yes. So for example, if someone for their happiest moment might have been the first time they held their child, and now they have chronic pain, they would say yes. I mean, it's even if I was in pain, that would still be the happiest moment. And so with that, it kind of explores that idea that for pain management, sometimes it's not really about lowering the experience of pain, but more so allowing you to experience more joyful, fulfilling moments in your life. So that way, like, you're in pain, and yes, like that's unfortunate, and yes, you can still like access like a still joyful and meaningful life. So that's all kind of, so where that kind of gets back to your question of like where marijuana comes into that. I don't know. I couldn't really tell you sort of like what I've never prescribed it, so I don't know much about like the medicinal uses. But again, people are going to use marijuana, and it's like being used pretty prevalently. So I think it's just something to ask people about sort of what their marijuana use is, and in a way that's like non-judgmental. If somebody's using marijuana and it's helping them access their full potential, like, I mean, I'm not going to, interfere with that.
Yeah. I'll tell you anecdotally, I've seen the use of marijuana, especially medicinal marijuana. It almost bridges a lot of the gaps that chronic pain therapies seem to miss, whether it's ability to sleep, ability to eat, giving you more of a lust for life. I mean, I think there's a role for both, not only narcotics, but adjuncts as well as marijuana itself in that same realm. And guys, smash the like button if you can, so we can get everybody back into the get into this chat. But yeah, so it's always a controversial issue, because some states allow it, some states don't. Some states it's recreational, some states it's not. But marijuana itself, in the anesthesia field, if you use a lot of marijuana, you are more resistant to anesthesia. It almost has similar properties without the detrimental effects, I guess. But yeah, like you said, it's quite interesting the way that it's perceived in different parts of the country.
It's something that like I'll ask patients about like their marijuana use, but it normally doesn't like change their course of treatment. I think there are like some select cases. I think particularly if you have a family history of schizophrenia or a really strong family history of other psychotic illness like schizoaffective or bipolar 1 disorder, then like I would really strongly caution against like the use of marijuana. But even then, again, like if I can give you that information and talk about how sort of like the use of marijuana can like increase.
Why don't you dive into that? What type of tell us a little about the, you hear a lot that chronic marijuana use can cause anxiety over a long period of time. It can cause chronic vomiting syndrome, all those kind of things. It's there are side effects to it. It's not a benign type of drug, right? It has side effects, especially if you use it all the time. What do you see?
Yeah, I mean, I think there's risks, right? Like there's risks with it for sure. Like we were talking about earlier. So if you do have like a strong family history of a psychotic illness, like marijuana does increase the likelihood of having a psychotic break. The thought is that people who do have sort of like a cannabis-induced psychotic episode, we're likely, if that does indeed develop into like a long lasting like schizophrenia, for example, the thought is that person was likely to develop schizophrenia on their own anyway if they had never used marijuana. But again, the marijuana just kind of up. But I sort of caution like against that thing, because like that when you say it like that, it makes it seem like, oh well, like it was inevitable, like I was going to get schizophrenia anyway, so I might as well smoke marijuana. But I can tell you, I mean, like when like if that costs you like a year of life without sort of the prominent symptoms of schizophrenia, I mean, like that time is really precious. I mean, it's a really challenging disease, and so as much as you can avoid it and have as much time, like,
do you think that it's almost not studied enough when it comes to different disease processes, or do you think that it's kind of in the infancy, or and for those guys who just joined, this is Dr. Ashai. He's a board certified psychiatrist in Austin, Texas. So we're going to go over a couple of questions here, and then we'll take questions from the audience. If you guys do us a favor and hit the like button so we can get all the people back that left, because this is our third try today of trying to get this going. But the part that I found interesting what you said was that marijuana itself has detrimental effects. The positive effects are there as well. Would you say, or would you say that it's kind of out there and it's not really studied?
Well, I think like with to the point of like it's not really studied. I mean, I think like one thing that we can say pretty confidently, right? Like the marijuana of today is not like of like the 60s, right? Like the THC content really high, and so I think I think that is like the issue is that like marijuana is used very prevalently, but the sort of like, the dose at which it's used can really vary.
That's true. That's exactly
so
true.
When you hear sort of like you're saying, like anecdotally, we hear it all the time where patients will say like, I smoke marijuana and my anxiety goes down.
Yep. Okay. I hear it a lot.
Right, but like, what dose were you at? Like, and then it's like, well, I smoked like one joint, but it's like, well,
what's in a joint? You don't even know what the dosage is in a joint.
Right. I mean, I think where it's like, I think that's the thing. Like where it's like now more legal. Like there's potential now for having that like dose response like relationship studied more. But I think like even now, like where things are at right now, most people are not necessarily using marijuana in like a very like controlled like dose manner where they know exactly how much they're taking.
Yeah. Continuing on with that, some of the most commonly prescribed drugs that are the biggest blockbusters in the history of the world include Zoloft and what's the other one that I'm missing? Prozac. Some of the biggest blockbuster drugs. Can you, for the audience, explain how they work and then what kind of trends you're seeing with those drugs in today's current practice? And what they're used to treat also.
So, sure, yeah. So Zoloft and Prozac, the question was about, so these are antidepressants of like the SSRI class. So these are what are called like selective serotonin reuptake inhibitors. What that means is they sort of increase the amount of postsynaptic serotonin that is present, and the hypothesis is that the long-term effect is like a downregulation of receptors that will eventually cause like a decrease in depression and anxiety as well. So it's something that, again, because we're talking about like the receptors having to be downregulated, like that takes time. That's why when if you've ever talked to a doctor about those medicines, they'll tell you that like, to wait like, 3 or 4 weeks to really see like the full effect of the medicine.
How do you gauge full effect? How do you know if it's working?
So I mean, it's a clinical assessment, right? Like, so you have to talk to your patients, and they'll tell you like sort of where their depression is at. We do use like a lot of like rating scales, like PHQ-9 and things like that. But yeah, I mean, it's really, I think, clinically, like you talk to your patient and see how they feel. That's really the most important thing.
Guys, we'll get to the questions, I promise. We have a couple more questions here, and then we'll get to your guys' questions inside the chat itself. If you guys can do us a favor and smash the like button, we'll get more people in here so we can answer some more questions. Now, Dr. Ishai, I just recently had a son a couple years ago. One of the hottest topics in medicine right now, if you follow Miss Rachel controversy or any of that kind of stuff, can you, as a child psychiatrist, clear it up once and for all? How much screen time is allowed for kids?
Listen, I think the American Association of Pediatrics, I think their recommendation is like an hour.
An hour a day.
I think that's admittedly I'd like have to kind of go back and research that, but to my recollection, like that's what I think the American Association of Pediatrics, that's what their guidelines say. But I would say don't take my word for it. Like look at what like the guidelines are, and you can sort of talk to your pediatrician.
Now what? So the way that the American Association of Pediatrics, they talk about two different. They talk about alone screen time and then guided screen time when you are actively participating with your son or daughter in whatever they're learning. Could you? A lot of people are saying LOL. Can you explain what that is? What is guided learning or guided screen time versus non-guided screen time?
So admittedly, I don't have a lot of experience in that area, so I'm not entirely sure what that would be referring to. But again, I think like when it comes to like the sort of the question of screen time and like sort of how to use screens effectively, because they're inevitably like part of our daily life.
Yeah.
So like we want to make sure like your screens are not like a babysitter, like, and it's not, you're not using the screens to pacify like your child, because then that can sometimes create issues like down the line. But
what kind of issues?
Well, I think just like you don't want to sort of rely on screens as like a way to as that kind of like pacifier, because then like, well, the issue that most parents you'll talk to that they'll have is like when they take away screens, like now like the kid is like tantruming really badly, and what do I do with that?
Yeah.
Right. If your solution when your kid is tantruming is to give them screen time, then like, well, now what do we do about?
Yeah. That's the problem I have all the time. We use the screen to pacify the kid, and then when you take it away, it's a big deal.
And you're stuck. I think like, so it goes back to one of these like basic principles, like when with kids, whenever you're telling a kid like to not do something, you have to be ready to like supply like an alternative activity, right? Like,
yeah.
Like I'm sure you've seen this with your little boy, right? Like if you just tell him like no, like don't touch the stove.
Yep.
Right? It's like, okay, well, what do I do then? Like, I don't know. So like you have to say like, don't touch the stove. Here, come play with this, like with this ball or something, right? Like, so I think that's the big thing. And really, so when it comes down to like reducing screen time, because that's really usually the context in which this conversation comes up. My recommendation to like with parents, like if you are going to reduce screen time, like make sure you're ready for it, right? Because you're going to need to supply the kid with like other activities to do. And so, like, if you, for example, like if you're a teenager, if you want to take away their Xbox because like they did bad on their report card, but like make sure they have something to do, and make sure that you are going to be able to like hold, like, your kid might just be making you, driving you up the wall, like, just be driving you crazy, and then you just give them the Xbox back so that, you don't have to deal with that. And then that's where you create problems where you weren't able to kind of hold that boundary.
Do you think that increased screen time can lead to like ADD or ADHD, since that's the biggest kind of thing going on? Is there a connection? Do you see it in your practice?
I wouldn't necessarily like I've seen that per se, but like I think that that there has been studies that have shown that like there is that connection that like with are some of these problems like and if there weren't, right, we wouldn't even be having this discussion, right? So I think like it's, a lot of this is intuitive. I mean, I think parents see it, like they see how.
Well, here's a question. The whole ADD ADHD still confuses me. Can you break that down? What's the difference between ADD and ADHD?
Well, so in the DSM-5, like it's just ADHD, but you will just have, so ADHD, it's attention deficit disorder hyperactivity. Attention deficit hyperactivity disorder. Sorry, it's late. But like there's subtypes, right? So there's like a predominantly an attentive type. So what sort of maybe colloquially would like be referred to as just like ADD, where it's just your attention is primarily the issue. And then there's like a hyperactive subtype where maybe it's just the hyperactivity that is really the issue, or in most cases we have, or I shouldn't say most cases, but in other cases there's the combined types, so both inattentive and hyperactive.
Okay, yeah, that always confuses me. And guys, we'll open it up for questions now. So if you guys have questions for a child psychiatrist, feel free to ask. I have a couple more that I'll go through, but if I see one when you guys ask it on here, I will ask Dr. Ishai as well.
Medical advice, though. I hope
all this advice is absolutely ask your primary care. This is all just for your information. This is not specific medical advice. And everybody who's on here knows that whenever I give advice as well, it's always defer to your primary care before you guys ask us anything. Now, let's see. You guys have any questions? People asking mean questions. Teresa says, ask your primary care doc. So here's a question we got from the audience. How can we open a discussion up with our children after a traumatic event?
That is a really good question, and it's one that I get a lot, particularly the work that I do, and particularly when I was in fellowship, and I was like, working in really highly acute, and parents would kind of always ask us like, well, like what do I say to my kid, like, now that something like traumatic has happened, like I don't want to say the wrong thing, I know this is going to be kind of a long-winded answer, but like, so there was like a really old psychiatrist, Winnicott, who had come up with this idea that really, like, you only need to get 30% of parenting right to have a well-adjusted kid. That's it. Just 30%. You can be wrong 70% of the time, but as long as you do it right 30% of the time, like, your kid's going to be fine. And generally what I tell parents is that's sort of leads into sort of the discussion with parents. Like, if you're well-intentioned and you love your kid, that's really half the battle. That's more than half the battle. Like, whatever you say, like, it's not going to be perfect, but it's going to be fine. Like, it'll be okay. Like, if that's the place you're coming from, like, we can work. Like, you can work on communication styles and things like that. But like, after something traumatic, like, if that's what you're able to kind of get across to your kid, is that, I really love you, I really care about you, and like, I'm here for you. Really, the rest kind of all kind of falls into place eventually. That's really just the most important thing. I just, and then it seems kind of, maybe like I'm dodging the question, but that is the truth. Like, if I generally, that's what I tell parents is just, just love your kid. Like, you are, I'm an expert on a lot of things, but like, you are the expert on your kid.
Yeah. Yeah, that's huge. I mean, I think a lot of time, because of social media, we get these ideas of perfect parenting or perfect images or perfect like scenarios. And it's like, how do I achieve that? And if I don't, I'm a failure. You know what I mean? Like, if you don't have the perfect kid all the time, then you're doing something wrong.
Which is crazy, right? Like, I mean, it's just so silly because, like, our parents weren't perfect.
No.
Right? As like adults kind of appreciate it. Like, our parents weren't perfect. Like,
Yeah.
Are we parents? Probably not. Like, we're gonna screw up.
Yeah.
But, like, it's gonna be okay. Like that. Just as long as the love is there, really, like, you can really work through anything. Like, it all really does work itself out. Like that. If the love is there, then, like, things might be hard, but even when they're hard, like, you'll get through it. Like, that's really the main thing. I don't know. I probably wasn't a satisfactory answer, but it's
no. I think it was good. Yeah. Let's see. I got one. Do you have any suggestions for dealing with the mental aspect of? Oh man, I messed this up. Nurse Nord. I don't know how to answer that question. Let's see. Evanest said, my son was 13 years old when he became anorexic a few years ago. Now he has full-blown body dysmorphia disorder. Do you have any tips?
So I can't give medical advice.
Maybe you can, don't give specific, but maybe you can talk to body dysmorphia disorder and how you treat that in your clinic type of thing.
Yeah, well, so body dysmorphia just kind of refers to like a person sort of being uncomfortable with their body, like in their own body. But the other diagnosis of like anorexia, that is like an eating disorder in which someone is restricting. There are subtypes of anorexia where people may be purging as well. But I think the important thing with eating disorder treatment, because that is really one of the harder things that we treat in psychiatry. It is more challenging.
How do you approach that? How do you approach eating disorders in general? And this might be a good point to talk about what we were talking about off camera was not only for the one side where it's anorexia and bulimia type of thing, but what about on the other side where you have binge eating? Is there any role for some of the medications that are coming out now for that too?
Yeah, so I think the important thing with eating disorder treatment is that it needs to be done in the right setting. So it can be really challenging when someone is really not at the appropriate level of care, like when you're trying to sort of treat someone at an outpatient level of care, but they really need like a residential level of care support because of the severity of their symptoms. That's what I find the most. I think that's what I think we see a lot in psychiatry is it's really difficult to sometimes to get people to the appropriate level of care because again, like the eating disorder really doesn't want to be treated. Like I think that's what makes it so challenging. Is like when someone has depression, like they may want treatment because they may not they may want to not feel depressed, right? But
Yeah.
someone who is going to it doesn't really work that way.
Yeah.
So that can be like really the challenge is just making sure that we're at like the appropriate level of care where they can really access the kind of support. The strongest treatment for eating disorders is that is evidence based is the like emotional focused family therapy, which again like it takes a village really like so just to again kind of paraphrasing some of it like for eating disorder treatment like it really you just can't do it like it's not something that like can be done like really like
You can't just tell them to start eating more or stop throwing up or that kind of thing. You kind of have to bring the whole family into it.
I mean it does take the family, and that is a big part of it. To be frank, I mean, like that is the treatment for anorexia. Like you got to eat. So like that's the other problem with that is the trouble with eating disorders. There's no like real perfect medicine for anorexia, but really food is the medicine. And so once you have like you're able to kind of have a remission of symptoms and sustain weight for like a year. That is really like the standard treatment in that kind of a disorder. I know you were right. Like we were off camera talking about sort of on the other spectrum, like binge eating disorder, and like some of the treatments for that. And that can kind of vary. Like there's like for binge eating disorder, like I think Vyvanse is considered like one of the first line treatments for that as well.
Vyvanse is what?
So that is a stimulant.
I don't know if you've seen my video on Vyvanse. Vyvanse is phentermine, right? Or phentermine, right?
No, isn't it like
Oh,
it's one of the Adderall salts, I think, isn't it?
Oh, maybe it is. Okay. Well, there's phentermine too, which I pronounce as phentermine. If you go to the comments on that video, everybody's like roasting me for mispronouncing phentermine, but correct me if I'm wrong. I basically said it's kind of like cocaine for your brain to help you lose weight because it works the same mechanism by increasing dopamine reuptake or inhibiting dopamine reuptake, which then stimulates your body, which then increases your sympathetic drive, and that in the end ends up making you less hungry.
Well, yeah, I mean, so Vyvanse though, it's like not the same as cocaine, right? Like the half-life.
Yeah, not exactly the same.
Different, right? So, but I think one of the other like emerging things, I know you've done videos about Ozempic, and it'll be interesting to see its application in something like binge eating disorder, and then also I think where I'm sure it's being studied now. I don't know of any like studies and trials or anything like that, but I'm sure it has to be because it just seems kind of obvious. But like using it as like using one of the like the Ozempic, like alongside starting like an antipsychotic that has a weight gain side effect. Excuse me.
So you think Ozempic has a role in the future for that type of role too? I've kind of pitched it to all my followers that Ozempic and or Mounjaro and or the other one that's coming out, they have a lot of applicability because a lot of the problems that come from medicine are usually have to do with weight gain. I mean, maybe not in the psych world as much, but probably too in the psych world because when you get to a certain weight, you probably get depressed and have a lot of anxiety and stuff as well, and you treat a lot of it or cope a lot of it with food, or the dopamine hit you get with food. But just general cost to the hospital.
That can happen. I mean, but really, I mean, you can be depressed at any size. I mean,
oh no, I know. I'm just saying that weight gain has a lot of tentacles in every single disease process almost.
Well, one thing I will say in psychiatry, a lot of our medications have weight gain as a side effect.
That's interesting. Yeah, talk about that. Why is that? Why do you think that is?
Because of it's like it has to do with the it's like the 5-HT subunit, like in the sorry, it's late. I'm not going to be able to. But it basically, like, the medicine, it hits this in order to hit like your the subunit of like the serotonin, it's also going to hit like a histamine subunit that's going to promote like weight gain. So that's the trouble. It's hard to get a medicine that's going to be specific for the kind of like the psychiatric targets. That's not so hit that.
Similar? Are they just basically similar receptors? So when you hit one, you hit the other type of thing.
Really hard to make. It's sort of inevitable. So, but particularly where that becomes like a big issue is like with our antipsychotics. So like that is something that like I'm really interested to see, particularly like some of the ones that are for like patients that are like really treatment resistant, that are on like something like Spazerol, for example, where weight gain is like a major side effect. It would be interesting to see like adding something like ozempic.
Yeah, that's exactly what I was thinking.
Yeah, because really, I think one of the biggest challenges, particularly in treating like a psychotic illness, is getting patients to take their medicine.
Yeah.
And that is, I think, again, I think, like we were talking about mood, you can be in any type of mood and any type of size, but that is a complaint that people will have, that they will stop taking a medicine if they feel like the weight gain is problematic for them.
I've seen it.
And so if that's the case, then that creates a lot of problems when people are not able to kind of stay on their medication that is providing them like the symptom relief. And then
listen, I'll tell you anecdotally, Ali, that anytime I've seen anybody who's started Ozempic, this is all anecdotal, by the way, this is not proven by any facts, but the people that take Ozempic, there are so many of them that get off their diabetes meds, get off their antidepressant meds, because they feel like they have a renewed lease on life. If that makes any anecdotal sense. I mean, obviously there's no studies. It's not even approved for that stuff. But there's just happier. You know what I mean? They're just like the amount of physicians that prescribe it off label is like insane. It's absolutely bonkers the amount of people that are on Ozempic or Mounjaro, because there's a coupon out for Mounjaro now for $25. You can get 3 months supply. And actually, our secretary in our department is on it. She was getting her injection today because she gets it on Fridays. She said she's paying $25 for a month for 3 months.
Like, what do you do after 3 months?
I mean, I'm sure it'll spike up to $400 or $500 a month, but she said she's already lost 22 pounds. She only wants to lose 8 more and then just keep it off. So the amount of people whose self-confidence is kind of almost increasing is wild. It's absolutely wild to me. I don't know if it's penetrated into the psych world as much yet, but just anecdotally speaking to people that are on it, it's like they have a renewed sense of exercise, getting out, walking, doing adventurous things, and all that. And the rule, it's exciting to see that they can kind of go into all different aspects of your life, not only your physical life, but your mental health too.
Oh yeah, I mean, I'm a little cautious about that, particularly like because I do work with like a lot of eating disorders, and I'm a little wary that I think like there is kind of like a lot of. I think it does kind of feed into like a lot of like diet culture and like
peer pressure.
Like that. And so I do kind of caution it a little bit, that I'm like, I don't know. I think that we kind of, like with all things, right? Moderation. And it's. And there's no like one size fits all.
Yeah.
But again, I think in the application in psychiatry, I would be really, really interested to see like for our medications that do have a strong association with weight gain and metabolic syndrome. If you start that medicine alongside Ozempic, like what would the long-term trajectory of that be? Because we have done that in the past with metformin, actually.
Talk about that, because people ask about metformin all the time. I'm on the fence when it comes to metformin. Some people have great results. I know it's been around forever. It's like a miracle drug. It's supposed to help aging and all this stuff. But what's your opinion on it?
Like I'm not an expert on diabetes. I really am. I don't have much.
Yeah, neither am I.
I couldn't really I don't really prescribe it a lot, but again, the context in which I would prescribe metformin is if I'm prescribing an antipsychotic that does have a side effect of weight gain, and I want to sort of make sure we offset that for a patient who's like particularly at high risk of diabetes or something like that. Like we would then go ahead and be proactive and start metformin. But yeah, I can't really speak to it other than that.
Yeah. Well, thanks for smashing the like buttons, guy. I really appreciate it. If you like Dr. Ashad, thanks for all the flowers and all that stuff too, as well, the roses. Another thing that somebody had asked earlier. Let me see if I can scroll back up and get to it. What is your opinion on the effects of sex drive and all that on SSRIs? Is it real? Does it happen? Are people losing their minds? What's your kind of opinion on that?
So it can happen, but it doesn't happen for everyone. It is a possible side effect with antidepressants that it can decrease libido. It can sometimes, for some people, it will increase the time it takes to achieve orgasm. And that particular side effect is sometimes actually used for like premature ejaculation. Like sometimes people will benefit from being on like an SSRI to prolong the time between like intercourse and an orgasm. But again, not everybody has that side effect, but if that is something that, like, again, it's not medical advice, but again, if you're concerned about like any particular side effects, like always talk to your doctor and just be honest with that. I think but to that point, like to expand a little bit, it is something that, like, it is really important to have those conversations like with your doctor about stuff like that. I know it can sometimes feel comfortable to like bring it up, but like, it is important because that's an important part of your life. If it's important to you, it's going to be important to your physician, and we're going to want to know about it and have those conversations so that we can help you meet your goals.
Yeah. And thanks for the likes. Hey guys, I added a couple of you to moderator status, so you can, if anybody's spamming questions and all that, you can go ahead and regulate that. I know it's getting kind of late. What other questions you guys have? Oh, another question that we get a lot on here is insomnia. I'm not an expert on insomnia. I'm an expert at putting people to sleep physically, but but I don't have the right answer for that. So how do you treat insomnia in your practice?
Well, I think when treating insomnia, the important thing is to understand really what is the cause of the insomnia, because it could be a number of things. That's insomnia is can be a symptom rather than like a disease state of itself. So it's important to kind of understand really what's going on holistically. But again, I think the first place you look is like sleep hygiene. Are there screens before bedtime? You want to eliminate that. Are you taking naps during the day? Eliminate that kind of thing. If there's things like that can be fixed with with good sleep hygiene practices, you always want to do that first. And furthermore, like even if you are exploring like medication options, like medication doesn't replace good sleep hygiene. It's something.
No, I agree with you there. Like Ambien, I've heard such mixed stories on Ambien. Some people love it, some people hate it, some people do. And for you guys who don't know, everybody just joined. This is Dr. Ashai. He is a board certified psychiatrist. All the people that are asking who he is board certified psychiatrist.
There is evidence for these medicines to use them in certain situations. I can tell you, I've never prescribed. I've never started Lunesta or Ambien. I've never done that. Because again, but it's also like the acuity that I'm seeing, like for a lot of my patients, like it's not necessarily. I haven't found it to be a good fit for a lot of the cases that I've seen. But I'm sure there are people who do benefit from those medicines. I just haven't used them.
Yeah. So we'll take a couple more. And
the reason for that is they're meant to be used in like short term. Like you're not supposed to be on Ambien for more than like 2 weeks.
Sharon gave a nice compliment about magnesium. Do you have any opinions on magnesium?
I don't have any opinion. I don't think there's anything wrong with it.
Yeah. I made a video about it. I take it on nights that I have stress or I want to get to sleep for after a long day or whatever, and I want to go to sleep early. I like it because it's a cofactor. It's not a excuse me, it's not a hormone directly like melatonin. A lot of people enjoy, or a lot of people take melatonin every single night. And my biggest thing with melatonin is that it's a hormone. It's not something that can naturally be regulated by your body. If you give something that's, in your body, give something from the outside in.
No, I don't think I've seen any study where melatonin in long-term use is really shown to be deleterious, because you would be having to take like massive doses, I think, of melatonin to really mess up your axis.
Yep. Yeah. No, I agree with you. I
like 9 milligrams of melatonin, like you're not going to do that. Like even if you do it every day, like it's not going to destroy your axis, right?
That's yeah. But and this is where all physicians differ on different things. And my thing is that it's not FDA regulated. It's a supplement. So you can be getting 1 milligram in your 5 milligram tablet. You can be getting 1 milligram, or you can be getting 20 milligrams, because there's such a wide variety of what is actually put into it, and the manufacturers and that kind of stuff. It for me, if there's an option that's more natural, magnesium comes, like you said, it's regulated, that kind of thing. I would prefer that over melatonin. Every day kind of thing. If you're taking it once in a while, like I said in my video, it's fine. I don't think there's an issue with taking it once in a while. I think it's those people that start giving it to their kids at 4 or 5 years old, and they're on it for the rest of their life. That's
I've never seen that. I mean, again, I'd be interested in seeing the literature on it. I don't think there is
literature on it. I don't think there is really. It's just
any data showing that it's like if you are on melatonin long term, it's going to cause any issues.
Yeah, that's true. Yeah, and I think there's no money in it, so that's why it doesn't get. There's no studies that are published by anybody, because there's no.
Yeah, I mean, well, maybe that's a good point. Like
the people that are making money off of it, they want to keep the status quo, and the people that could potentially make money off it don't care because it's such a small market.
I mean, but I would rather like someone take melatonin than like Seroquel.
Very true. That's very true. Yeah.
People are on Seroquel for sleep, and I'm like, nah, dude, like you don't need to be on like Seroquel for sleep.
Yeah. No, you're right. That's a fantastic point, because if you can choose a melatonin over Seroquel, I would take melatonin 100 times out of 100 over Seroquel.
Yeah.
Somebody in here just put a link to a study, but we're not going to be able to click it on here. Okay, so maybe we can get one more question in, and then call it a night, because it is 10 o'clock here, and I know it's 9 o'clock for you, so you probably have things to do since you're in Austin, Texas. You guys have a good question? Give me like a good question that comes to mind that doesn't have to do with Mounjaro or Ozempic, because all the questions are about Ozempic, Mounjaro, or what's the best. What'd you say?
I'm really interested in seeing like if it does have an application in some of those areas, because it could really improve quality of life for a lot of people, like that are on like high dose antipsychotics with severe weight gain as a side effect. So
yeah, guys, give me a generic question. He's not going to be able to answer something specific about your son or anything like that. And anesthesia questions that maybe I can answer after we're done. And yes, redheads do require more anesthesia. So let's see. Do you have any experience with gabapentin? You probably don't do much with gabapentin, do you?
No, I use gabapentin. A good bit.
What is so a lot of people are asking about benzos and gabapentin. Well, pick one, whichever one you want to talk about, whichever one you know better about.
So like benzodiazepines, I mean, like there's like a time and place for them. I mean, they can be used like as like an adjunct in treatment for anxiety. It is a good important for panic disorder, like to stop panic attacks. But it's not something you want to be on long term. I think like if you're using your benzodiazepine to kind of bridge your treatment as you're sort of working in therapy, or also working on maybe getting like your SSRI to a therapeutic dose or something like that, then I think there's definitely a place for that. And then of course emergency situations, like there's definitely good time to use benzos. But I think what I see a lot of, unfortunately, I think the way it was prescribed, like in previous generations, it seems like you will. I'm sure you've come across this too, like people that have been on like, Klonopin, Valium, or Xanax for like, 12 years.
Yep.
And it's like, and then that does cause problems for sure. I think there was a study that showed that it was believed originally that benzos was increasing your mortality risk because it increases your risk for falls, but it actually showed like an all mortality increase in chronic use.
What are some long-term side effects of being on a benzodiazepine? Is there any link to like dementia or anything like that?
Yeah, big one. Dementia, and then all-cause mortality. Like you're going to die younger if you're on benzos.
I recently found out, and this is new to me. Did you know that glyphosate, whatever the heck that is, the herbicide they use for Monsanto, the U.S. FDA has a much higher level of accepted glyphosate. I can't even say the word. I call it glyphosate, but it has a much higher level. It's been linked to decrease. The International Agency for Cancer Research has said it's potentially cancerous, and not only that, it's very high parts per million in Quaker oats and on the cheap oatmeals, and it has been linked to Parkinson's. Now I'm blanking on the other types of dementia because I looked it up for the video that I made. But anyways, and it's prevalent in all sorts of foods that we. I mean, it's very prevalent in oatmeal, but it's also prevalent from the comments I'm seeing on the TikTok. It's in all our vegetables and in like wine, all sorts of things. And I don't think it gets any attention really in the mass media because it's Monsanto, and Monsanto actually changed their name. They're not Monsanto anymore. After they got sued, they changed their name to something else.
And yeah, I don't know anything about that. Truthfully, I do think though one of the things I see a lot of, unfortunately, is there's like a lot of like, and I do try to get away from that. Like where there's like a lot of like kind of like food shaming, where like food is like kind of like cheap and affordable, like it's labeled like bad, but no food is like bad. If it's again like all things in moderation. And
I used to mix oatmeal with every protein shake. I'd have oatmeal, and then I'd have a bowl of Quaker Oats brown sugar. Is that what it was? The brown sugar flavor? I don't know if you remember, but I used to eat those all the time in college. And
on my pantry right now. I mean,
you gotta get the Costco brand. It's called Farmers Grow or something, and it says glyphosate free organic. That's the one. I don't know. I'm not sponsored. He's not sponsored, but
I think I'm in Texas, so I roll with HEB. So
Texas, it doesn't matter, right?
It's HEB or nothing.
HEB or nothing. All right, brother. Well, it was fantastic having you on. Thank you for coming on, and thank you guys for tuning in to our chat. This wasn't how we intended it for it to go. He didn't know. I didn't know that you need to have 1,000 followers on TikTok to do a live together. In my next contract I send out to the next guest, I'll make sure that they have 1,000 followers. If you guys can go and follow him, that'd be fantastic. So then we can have him on a real live, so that we can do it split up. Hey, give yourself a plug, Ali. Where do you work? All that kind of stuff.
Yeah, I guess you can follow me. I think what is mine? It's the Ink Shrink MD.
Yeah, you got the ink on your hand. Fantastic.
So I honestly, unfortunately, I don't post like a lot or ever, but maybe I'll start doing that. This was fun, so yeah, maybe we'll start getting.
Yeah, you know what I'll do is I'll chop up some of the clips from this interview, and then I'll put it on mine, and I'll tag you in it, so you guys can find him on there too.
Oh, that'd be cool.
Yeah, so then you guys can follow him. I'll stick around for a little bit, Ellie. I know you got to get out of here. I'll stick around for a little bit and answer a couple questions before I get out as well. Glyphosate, that's the word. Somebody posted it in here. Dr. Parizzi. Glyphosate. Look it up, man. See what it is for the next live.
I'll look into it. But hey, man, thanks for having me, brother.
Good seeing you, my man.
All right.
Later.
Adios.
See ya. All right, guys. I'll stick around for a couple more questions. Ali's a dear friend of mine. I've known him for years. He's a fantastic psychiatrist. He actually cares a lot about people, and that's why he. You could tell from his answers. He's very good at what he does, as opposed to. I'm a little bit more. Let me see if I can fix this so that. Oops, sorry for the loud noise. All right. He's way more caring and loving than I am. So he's a fantastic guy. He said he did say no food is bad. So he is a. Dr. Parizzi, I'll chop it up. I think his name is Ink Shrink MD, but I'm not sure. He might join back in. I'll tell him to join back in so that he can plug himself. But he's a fantastic guy. I'll answer a few more questions. Stick around. And you guys, thanks for smashing the like button. I know I wasn't able to kind of go as fast as I usually go because he was answering his questions, and he's a psychiatrist, so they take their time and doing all the stuff that they do. You guys go ahead and ask away any questions you got, and I'll try to answer as many as you could. How's your day going? Let me turn some music on too so that we can jam out a little bit. If you sent me a DM about Mounjaro and anesthesia, I think user ABCDFU, that's a funny name. Mounjaro does increase your risk for what they call as a full stomach. So if you're on Mounjaro, if you're on Ozempic, there's no official rule as to what you should or shouldn't do. But normally, typically before you have surgery, we tell you to not eat anything after midnight. If you're on Mounjaro or Ozempic, I would probably say extend that before midnight. So try to stop eating by 6 or 7 o'clock at night, just to give yourself an extra 4 hours to digest the food that you have to digest. So that means like if you're going to have surgery, typically we tell you to stop eating at 12. If you're on Ozempic or Mounjaro, try to slow it down or try to wait a little bit longer with your NPO status, which is nothing by oral, or I don't know what the N stands for, but I just go with nothing per oral.